Hey Ubba-Bubba, welcome to JuanMD. My name is Juan, and recently I got this book called Step Up to Medicine. It's a really nice book. I got it on Amazon. It was supposed to arrive on the first day of January, but it arrived on my birthday, December 20. Reading it so far, it's been a really nice book. It gives a really comprehensive understanding of clinical pathologies, clinical management of these pathologies. Today I am going to share with you 3 topics that I find interesting. The first one is aortic dissection, the second one is atrial septal defects, and the third one is hypertensive emergency. I know my video topics tend to jump from here to there, being so random, but these are my videos. So the very first one we're going to be talking about is aortic dissection. Aortic dissection usually happens in patients who are hypertensive, who have kidney problems, patients who are pregnant, patients who encounter trauma, acute trauma, or patients with connective tissue diseases like Marfan syndrome or Ehlers-Danlos syndrome. So what happens is there is, dissection in the wall of the aorta. It can either go from down to up or from up to down. So the one that goes from up to down is called a type A aortic dissection. It usually affects the arteries that emerge from the aortic arch. I'm gonna get my handy dandy Netters. Netters is a great book. I've been using it for anatomy ever since first year med, and it's like essentially an artwork in itself. Netter was an artwork. Unfortunately, he died in 1991, but still his blood runs in this book. That's kind of creepy. So if we look at the aortic arch here, it comes out of the left ventricle and it does this arch, hence aortic arch, and it goes downward. And we can see that the 2 very first arteries that are hit are the left subclavian and the left carotid. So when a patient has a descending aortic dissection or a type A aortic dissection, you are going to see a blood pressure difference in the left and in the right. As the carotid artery is going to be affected, then we can see some hemiplegia. Since the left carotid artery, we can probably tell that it's going to be right-sided hemiplegia. Now, there's another kind of aortic dissection. It's an ascending aortic dissection, and it comes from the, lower aorta, and it goes upward. So these patients are less likely to have like a blood pressure difference. The chest pain can be is usually anterior for a type A dissection, and it's usually between the scapula in type B dissections, although that can overlap. You can also interrupt cardiac blood flow, and because of that, you can also cause a myocardial infarction for these patients. How do you diagnose an aortic dissection? Well, it used to be through angiography, but now what they like to use is the CT angiogram. So the CT angiogram is much more accurate. Then you want to also use transesophageal echocardiography. It's sensitive, it's specific, it's non-invasive, and it can be performed on the bedside. So how do we manage patients like this? The first thing you want to do is to do some blood pressure control, maybe with some beta blockers. And the reason being you want to do that is so that you can prevent any shear stress on the aorta and you prevent, therefore, further dissection. You can maybe start with esmolol and then you can work up from there. Then maybe you can add some nitroprusside if the beta blockers don't work alone. And then, depending on what type of dissection it is, you want to go for either surgical or pain management. So if it's a type A dissection, definitely go straight into surgery so that you can repair the defect. For these patients, the longer surgery is delayed, then the risk of death can increase by 1 to 2% for every hour that surgery is delayed. So that means surgery is an emergent need. And then if it's an ascending dissection, then you want to do some pain control. So maybe you want to give some morphine, hydromorphone. And then if the pain is still uncontrollable, maybe it's a sign that you have to do dissection. Okay, we're done with aortic dissection. Now it's time to talk about atrial septal defects. Atrial septal defects are these congenital defects in the atrium. It can be an ostium primum, ostium secundum, or a sinus venosus defect. Ostium primum defects usually happen in the lower part of the atrial septum, while sinus venosus defects usually happen in the superior part of the atrial septum, whilst ostium secundum defects happen somewhere in the middle. Now, this is a congenital defect, but symptoms don't usually manifest until the patient is like 40 years old. especially if the defect is really small. Now, if the defect is small, then when you auscultate, there's going to be a harsher murmur, whereas larger defects tend to be more symptomatic, but you don't tend to hear it as loudly on auscultation. The classic finding is a split S2. Then you're gonna hear a late systolic sound in the pulmonary aspect of the heart. Then you're gonna hear a rumble in the tricuspid aspect of the heart. What effect do atrial septal defects have on the blood flow? Well, because there's a septal defect in between the atria, then blood from the left atrium tends to flow into the right atrium. Since the right atrium is getting blood from both the systemic and from the left side, then it's going to try to push harder to send blood forward. Eventually, the right ventricle is going to follow suit, and there's going to be resulting pulmonary hypertension, although this is rare. There's also this thing called Eisenmenger syndrome, which is when the shunt reverses, instead of going from the left to the right, it goes from the right to the left. We know that right-sided blood is non-oxygenated. What's going to happen is that non-oxygenated blood is going to be pumped into the system, and you're going to have cyanosis, which usually starts in the toes because this is like distal, and it like gets the bare minimum of what oxygen is left. You can also have clubbing in the toes. Is that it?
No, that is not it.
And then you can also have arrhythmias, especially atrial fibrillation. The signals that supposedly pass through the atrial septum are disrupted, and so hence atrial fibrillation. You can also have right-sided heart failure. The right increased work of the right heart, then it can become tired, and then you have right-sided heart failure. And then, since there's a lot of pumping from the right ventricle, it can also cause pulmonary hypertension. One last complication would be a paradoxical embolism, which is when a blood clot from the lower extremities goes into the right atrium, but instead of turning into your good old pulmonary embolism, it travels through the atrial septal defect, through the left atrium, through the left ventricle, and into the carotid arteries, where it lodges itself in the brain, causing a stroke. Paradoxical embolism. Now, how do you diagnose this? Very crude. You can do a chest x-ray and you're going to see increased pulmonary vascular markings. On ECG, you could also see signs of a right bundle branch block. Most accurate would be transesophageal echocardiogram with a bubble study. What's going to happen is you're going to pump these tiny bubbles in the heart, move from right to left and through the defect. Okay, I kind of regret singing that, but oh well. How do you manage these patients? If they're not symptomatic, usually you don't. But if they're symptomatic, then you might have to do a repair surgery. Or if you test them and you see that the blood flow between pulmonary and systemic circulation is 1.5 to 1 or 2 to 1, then you might want to consider doing a surgery. And that's for atrial septal defect. Now, last but not the least, let us all talk about a hypertensive emergency. But first, let's have some coffee. Yeah. A hypertensive emergency happens when a patient's blood pressure is above 180 to 120 and manifests with some end organ damage. So you could have edema in the eyes, papillary edema, and then you could also have heart problems, myocardial infarction, unstable angina, aortic dissection, ding ding ding. In the kidneys, you could have renal failure, you could have oliguria, and in the extremities, you can have edema, and in the lungs, you can have pulmonary edema. One notable complication of this is called posterior reversible encephalopathy syndrome, which is not necessarily posterior and not reversible. It happens when, because of the increased blood flow, you have edema forming in the brain, and you can have problems with fainting, you can have seizures, you can have altered mental status, posterior reversible encephalopathy syndrome. Now, what can cause this? First and foremost, it can be caused in a hypertensive patient who doesn't take their meds, who doesn't adhere to therapy, in a renal patient who does not undergo dialysis, in a patient who is pregnant, who has preeclampsia. You can also have this in patients with adrenal problems, So hyperaldosteronism in patients with Cushing syndrome, and you can also have this in patients who abuse drugs and in patients who have alcohol withdrawal. You also have a cousin of hypertensive emergency where a patient has increased blood pressure, but unlike hypertensive emergency, they don't have end organ damage. This is called hypertensive urgency. Now, for both cases, you definitely want to lower the blood pressure. Typically, you want to lower the blood pressure between 10 to 20% within the first hour and another 10% within the next 23 hours of treatment. In these patients, you want to decrease the blood pressure using beta blockers such as esmolol, labetalol, or you can also use nitroprusside, you can use hydralazine. And if the patient has hypertensive emergency, you definitely want to admit them. If they don't have hypertensive emergency, if they're just hypertensive urgency, they can be treated as an outpatient with oral antihypertensives. Then, if the patient does have posterior reversible encephalopathy syndrome, you might want to do correction of electrolytes, so you can prevent further edema. Then you want to also manage the seizures with anti-seizure medications. And there you have it. I have now just discussed aortic dissection, atrial septal defects, and hypertensive emergencies. I hope you like this video, guys, despite how random my topics are today. If you like this video, kindly press the thumbs up button. If you've already pressed it in the past, please don't press it again, otherwise you're gonna unlike it. Then also click on subscribe and hit that bell so that you can stay tuned for future videos. Again, guys, this has been Juan. Until next time, always remember to listen to your heart. Wait a minute, that's not my line. Always remember to live life to the fullest because you only have one life to live. Coffee.
Na 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 na.